I'd like to introduce Dr. Jerome Lisk. He got his medical degree from the college in Virginia, in Richmond, Virginia. He did an internal medicine internship at UCLA out here in Los Angeles. And then a neurological residency and also a movement disorder fellowship, which was an extra couple of years at the University of Texas. So he's had a lot of educational training. Today, he works in Pasadena, California, at the Huntington Hospital, Pasadena, California. He is also an organizer and the chair of the steering and planning committee of the Southern California Movement Disorder Society. This is a group of movement disorder specialists who get together quarterly to discuss many, many issues. And we also have with us Dr. Nick Szumski. He had his MD at the University of Iowa, his neurology residency in UCLA, where he's the chief resident in his final year, his movement disorder fellowship also at UCLA, where he worked under Dr. Jeff Bronstein, who is the director of the entire movement disorder department. He was also a faculty member at UCLA Department of Neurology. Today, he is practicing at Cedars-Sinai Medical Center, where they are trying to build a world-class movement disorder department under the new leadership of Dr. Lydon, who has recently moved up to the Los Angeles area from San Diego. Dr. Szumski's clinical practice is in general neurology with a special emphasis on movement disorders. Now, I just want to go into the fact that there are several people who might have submitted similar questions, so the questions might have been modified in order to combine several questions on the same topic. If you would like to submit a question during this webinar, please go to the GoToWebinar control panel, which is on the right side of your computer screen, and type in your questions. If you have a PC, the image on the right is what you should be seeing, and you see there the area where it says, enter a question for staff. If you have a Mac, the image is on the right where it says, type questions here. Kate DeSantos is going to be compiling these questions for us, and somewhere in the middle of this webinar, we will break from the questions that we have slides on and submit these additional questions. First question, doctors. This is from Bill J. in Mason City, Iowa. I have been diagnosed with PSP. What are the chances of passing down this atypical Parkinsonian disorder to my children or grandchildren? Doctors?
I guess we forgot to decide who will go first, so I'll volunteer.
Okay.
This is Dr. Szumski. For the most part, we do not have a clear sense of heritability of disorders like PSP. There are some families out there where it appears to run in the family, and I think we'll get to some questions later that might suggest reasons why, because there is probably a genetic connection in some or all cases. But in general, it's not something that you should worry about handing down. That can put a tremendous and perhaps inappropriate amount of fear or even guilt about what might happen to your children or grandchildren. I think in general, it's not something that is typically going to be passed along.
Yes, this is Dr. Lisk. I'd like to agree with Dr. Szumski. There is a rare, the only genetic PSP that we know of right now is the autosomal dominant form that is very, very rare, and where 50% of the offspring will be affected. But for the most part, we don't really have a clear understanding of the genetics of that.
Next question from Bobby J. in Chicago, Illinois. I have some type of movement disorder that was diagnosed just a few months ago. My doctor is not sure if I have PSP or MSA. Of the treatments that are under investigation, are there any that can be taken over the counter and outside of a clinical trial?
Well, I do not believe there are any medications that can be taken over the counter for PSP and MSA besides treating the symptoms symptomatically. The ones that are under investigation right now, you actually have to be enrolled in the trial. And you could probably go to clinicaltrials.gov or go to other websites that will tell you the name of the trial, the location, and give you at least the site so you can see about signing up.
This is Dr. Szumski. I'd like to add that there are supplements that are being tested. In fact, there's quite a few in the case of PSP that may be available over the counter, coenzyme Q10 being top of that list, but also including things like creatine and a few medications that are available on the market, not over the counter, but on the market for other things. Lithium is one, Depakote as seizure medicine is another, and there are others out there. But some of them, some of the supplements have no major side effects, and you could consider taking them with a discussion with your doctor. But many of the medications that are being tested, we don't know if they're necessarily appropriate or even safe. So it wouldn't be advisable without really a careful discussion with your own doctor about just taking one, because just because it's in a clinical trial does not mean it's appropriate.
Also, to add to that, another one that's older medication, methylene blue, is another one that's prescribed. The lithium trial that's going on right now, the patients are actually having significant side effects for a lot. I think they've closed enrollment. And the valproic acid study, I know they've had a number of patients that had sedation of that. That's out of France. That's going to be published soon, 2010. The coenzyme Q10 study, which you get over the counter. There was a Parkinson's trial that showed a small benefit for that, and they also had another trial on PSP. And I think that most movement disorder neurologists are saying, with the trials of coenzyme Q10 that have already been out, they've tried doses all the way from 400. Now there's one of going over to 2,400 milligrams for Parkinson's. Trying 1,200 milligrams, if you try coenzyme Q10, trying 1,200 milligrams would probably be the best dose. But like I said, there's not really, besides that one small study with progressive supranuclear palsy where they go to, I think within a 6-week period, about a 1.5 point improvement in the rating, PSP rating scale. The coenzyme Q10 right now, the jury's still out. But it's safe, but it is expensive too.
But from a personal point of view, this is Larry Schenker in person. I'm a lay person. My wife has been taking that for the past 4 months, 600 milligrams twice a day. She's had no ill side effects, and she feels that she has had a positive energy increase. And this is typically what has been reported to us at our support group meetings also. Next slide, from Tustin, California. I am in the early stages of PSP, being diagnosed in March of 2009. However, I believe that I have had disorders since the winter of 2008. What are the benefits of participating in a clinical trial? Why should I?
Okay, so well, the benefit of participating in a clinical trial is, number one, some of the medications that we mentioned, such as lithium, Depakote, those are basically prescribed by your doctor. You don't need to do a clinical trial for those, even though your physician may or may not prescribe those based on the clinical data that's currently available. However, the newer medications, such as there's a medication that's like lithium that's in a clinical trial right now as well, and it's a GSK3 inhibitor. That those medications, that are not available by prescription, may or may not, show benefit. The upside of the trials, if you get in a trial with a medication that's not currently available, it's only available investigationally, and it shows benefit, then you may do better. And then on the other hand, you get in a clinical trial where the medication may have side effects, or it may not show any benefit. So, it's a risk either way.
I would just like to add that, it's a tough question, because I know I've worked with some people who feel that they're under some obligation to be in clinical trials, and I also have worked with people who have decided in advance that they will never participate in a clinical trial. And I caution against both of those positions. The appropriate time to be part of one is when it fits your schedule, your level of risk that you're willing to take on, and your view of the sort of the greater purpose. One of the biggest reasons to participate is for the knowledge gained. And sometimes that knowledge is useful and we take a step forward, and sometimes that knowledge turns out to be not very helpful, and you may look back and wish you hadn't spent the time or the energy doing so. So the best reason to do it is because that's how science moves forward and how treatment moves forward.
I'm in the early stages of PSP. I just told about hyperbaric oxygen therapy, abbreviated HBO treatments for strokes, certain brain damages. Is there any discussion about this treatment in relationship to either PSP or CBD, and then also in relationship to PD, which is Parkinson's disease?
So this was something I'd heard of, but wasn't sure what the current literature was. I went and looked it up. I do know that there are a number of practitioners offering this treatment for all of these disorders and many more. The trouble is that we don't have evidence, and I confirmed this by doing a pretty careful search of the literature. We don't have evidence that it works for many of these disorders. So unfortunately, there is a financial incentive for those who have this technology, and there may be a motivation on the part of a patient who feels they are looking for something new to try it, and you get to try something new and they get to charge you for it. That may sound a little cynical, but it is not an inexpensive treatment, and I would advise speaking with your physician if you're interested in trying something like this, about the pros and cons of doing it. Because in my reading of the literature, we don't have evidence that it would necessarily be helpful. You can create a storyline that might suggest why it could be helpful, but unfortunately, that doesn't always pan out to actually be useful in the end.
If there was money available, would it be advantageous for some large medical university center to test this concept?
That's a tough question, because I don't know if the storyline, of trying to get oxygen to cells that are potentially being damaged, I'm not sure that this connection is strong enough on a theoretical level to undertake what would be a pretty large-scale, high-expense study. The reason being, there's a finite amount of research dollars available, and you want to make sure it goes towards the things that have the highest yield. That said, there may be people working on this on animal models or in other settings who may be able, if consulted, may be able to provide some background evidence that suggests this could be useful. If that were the case, then I think it would be an interesting direction to consider. But to my knowledge, I don't know that we know enough to justify the outlay yet.
I would agree with that. We don't have enough just basic science evidence or any theoretical evidence to show that the treatment may work. And I did also significant research on looking this up. I couldn't find in the neurology or the movement disorder journals where there's been any reports of hyperbaric oxygen treatments. And I searched the entire journal through the search engine. There was on one message board I saw that there was a patient that mentioned a gentleman in the Philippines with PSP. They had some dysphagia and ataxia that received 20 minutes of therapy at 25 feet pressure 5 times weekly, 5 times throughout the week, and that there was some improvement. But that, of course, is just from secondhand report, or third-hand report. But there's no literature supporting it. There is a physician in Florida that has a website. I know Dr. Perlmutter that offers it as well. But I definitely agree with everything that was previously said. So.
Next question. My husband of 40 years has SA. He was diagnosed just a few weeks ago. How can we contribute time, effort, money towards a research program that might discover some treatment or cure for MSA in my husband's lifetime?
Well, that's a question. Also, you have to be careful how you contribute your time, your money towards certain research programs. You definitely want to research the research studies that are being proposed if you're going to finance something like that, and look at the evidence and the science and the previous literature concerning that, because as we said before, there's a finite number of research dollars, and you want to have some evidence going forward. As far as the time, like was mentioned before, also participating in research trials is also a good use of time as well, if it's something that you want to do and fits into your lifestyle at that time. So that's it for me.
My husband was a professional athlete in his younger years. He is still very much into physical exercise until he fell a few times playing one-on-one basketball with our grandson. What are the effects of exercise on PSP, and are any types of exercise recommended?
My answer is going to have sort of 2 levels. There are some signs of evidence in other disorders, Parkinson's disease among them, that certain models improve under exercise conditions. There was a recent study that showed when people with Parkinson's disease were pushed in exercise, they actually showed more improvement than if they just exercised in more of a relaxed setting. I don't know of the same degree of research in PSP, but in my mind, some of the logic carries over. When people exercise, there are release of certain factors in the brain that promote nerve growth and nerve health. While I don't know for certain that those are particularly useful in PSP, I like to hope that they will turn out to be when it's all said and done. The other level is simply that exercise prevents some of the complications of PSP or other disorders, not just that one. But what I mean by that is the more time spent seated or lying down, the less time using the muscles and joints, the more problems can be prone to setting in. Joints can become stiffer, muscles can become shorter and weaker, and it actually makes exercising on the line potentially more difficult. So exercise helps maintain, if not always improve, function. The key, though, at all times, is safety. You don't want to do something that puts you at a risk for an injury that would set you back even further. And in PSP, with the risk of falls, doing something that would lead to a fall and a potential fracture of a bone would be something you definitely want to avoid. But there are many ways to exercise with safe conditions and supervision that can be quite useful ways to keep the heart in good shape, the bones and joints in good shape, and try to keep function as top-notch as possible.
Larry, this is Larry.
Go ahead.
This is Janet Edmondson. I just wanted to comment. One of the things I've heard a lot of people talking about recently is the recumbent bicycles as being a great way to keep exercising and being safe. So I just thought I'd throw that out.
Yeah, and actually, thanks for mentioning that, because that reminds me, there are other devices. There's, for instance, a walker that I think many people on the webinar may already be familiar with. It's been discussed with some of the local groups here. It's called the U-Step walker. No financial or official relationship with the company that makes it, but it's a very stable, low center of gravity walker that can be very appropriate for people with who are prone to falling. It doesn't prevent fall entirely, but it can reduce the risk and allow for more walking and just keeping healthy, exercising in that manner.
It's very good for PSP patients who have a tendency to fall backwards because it is weighted in the front, which helps too if the person is holding it from falling backwards. I know that my wife Roberta, we don't have that particular walker, but we've added some weights to the front bar of the walker, and this gives her more balance. The only difficulty is it kills my back when I have to take it up and put it in the car.
This has also reminded me of one other thing, and that's that what we did for my husband was a lot of range of motion exercises, kind of going on what you were saying about keeping the joints so that they don't get pain. He got pain in his shoulder, and just by doing stretches and range of motion, moving the arms and legs through their full range of movement actually helped, I think, to prevent some pain, maybe more than keeping them limber, but really helped from that standpoint.
Okay, the next question, I know we've covered part of this already. This is reference to COQ10. And the question is, does the COQ supplement help any? And I think we've covered that one already, so I'm going to go on. Before I was diagnosed with CBD, I agreed to be an organ donor upon my passing. I want to help other people with my heart, lungs, eyes, and other healthy organs. My wife, children, and I have been discussing the pros and cons of donating my brain to CBD research. How will donating my brain benefit future generations of people?
Well, I believe that the more research we can do, then the more knowledge we'll collect. Many times they'll do brain autopsies, and they will the pathological research, and also the biochemical research that they learn is can be very helpful.
Yeah, I would just add that donating your brain, it can be a difficult decision to make. I think sometimes that's because you're talking about something that happens after your own or a loved one's death, and that's a difficult topic. But at the same time, deciding to do that is one of the most altruistic and generous things you can decide to do. It's extremely valuable because it's information for research that we literally can't get any other way. And so the amount of research that's done with donated brains is very valuable, but it's limited because there's only so many there. And a lot of people have a lot of very good questions to answer using that tissue, those brains. So the more that's available, the more knowledge for the next generation of people suffering from the same sorts of disorders.
And we'll talk a few minutes later, but during Dr. Borderline's webinar a couple of weeks ago, She gave a sub-presentation by a Dr. Gerald Schellenberger, who has done something like 1,300 brain used 1,300 brain cells in a study, and we'll show some information about that in a few minutes. From Barry G. in Newark, New Jersey, thanks for doing this webinar. My wife has PSP. I understand that the website called clinicaltrials.gov is a registry of clinical trials conducted in the United States and around the world. Can you please give us more information about how to best use clinicaltrials.gov?
I think it's my turn to start. So clinicaltrials.gov it's actually a fairly straightforward website. The idea behind it is a mandate to get every scientific study to register itself before it begins. That helps us assure that studies aren't being done and then thrown away because they don't appear to be profitable or positive, and then we don't know that information. So that's the gist of why it exists. Because it's increasingly becoming an up-to-date and comprehensive list of all of the studies going on across the country and around the world, it's a tremendous resource for people looking for what's on the cutting edge of research and even on finding something to participate in yourself. It's fairly easy to use. If PSP is what you're looking for, doing a search on PSP will give you a lot of studies on PSP that are going on now. I know, unfortunately, PSP can stand for other things, and you'll get a little bit of stuff that isn't related. But if you use just a discriminating eye, you'll find it's fairly simple. And the same goes with typing in CBD or corticobasal would be sufficient, or typing in MSA or multiple system atrophy. Same sorts of things. You'll get listing of all the things registered now with the government of clinical trials going on and their status. Are they looking for new subjects to join? Have they closed? If so, when? And then you might have an idea about when that information will become published.
Dr. Szumski, this is a U.S. government website. Does it also show research that's going on around the world?
It does, because the mandate, it's not about requiring this for funding, although that may come down the pipeline, and some funders actually do require this now. That there's a very strong push to require all major journals to ask the people who submit data to prove that they've done this, to set the motivation very high. And again, it's to make sure that people don't start a study and veer off and never tell anyone what they found because they decided it wasn't worthwhile or they didn't want to do it. It basically says, look, tell us when you start so we can wait the results. And it's a fairly new process. It's only a couple years old that the mandate has been in place, but it's taken hold, and I think you can rest assured that the vast majority of quality research going on is going to be listed in there.
So Dr. Colby 2 weeks ago mentioned a new study that's coming out of Spain. I don't remember what the name of the medication was, although it begins with an N, starting in 2010. That will be listed there?
Well, I can't say for certain. Ultimately it's up to the investigators to decide whether they adhere to this push. They do run a risk if they don't register. There are many journals around the world that will not accept their data. Okay. They're trying to say this is how we want people to perform the research, so we know what all is going on out there.
I assume it would be listed because I think Dr. Colby is going to participate in it. I know that Dr. Portalon at UCLA is participating in it. So it is a major study. Is
that the frontotemporal dementia / PSP trial, or is that the GSK3 inhibitor?
GSK3 inhibitor, which begins with an N. That's what the name is.
Well, the GSK3 inhibitor is it's just the study drug's number. It's NP031112, and then the other one, which is an octapeptide, is NAP, NAP.
But they would be listed in the clinicaltrials.gov.
I'm not sure. I think what Dr. Szumski said probably holds true.
Okay. Spouse has PSP. Has the research gotten to the point of any medication or surgery that would be really beneficial to PSP patients?
Well, for PSP patients, as far as surgery goes, there's deep brain stimulation does not work for PSP. In the two sites that we use for Parkinson's, which is the substantia nigra, with the subthalamic nucleus FTN and the globus pallidus. Those are the two sites. There is a research trial going on at this time for a different site called the PPN for those patients with PSP, but that's still investigational. As far as medications, the only medications that I think that have showed any type of promise are probably the coenzyme Q10. Like I said, that showed within 6 weeks of the patients taking it, they had they had about a 1.5 improvement in their PSP scale, and the average deterioration in PSP is about 1 point in the PSP rating scale per month. So you're not only halting the disease, you're almost like you're improving it. But that study is undergoing at this time. Also, the lithium study, it does not show any good results. The valproic acid study, I don't think anyone's too sure about that. They have to wait for the results to come out in 2010. The only thing I could possibly say, the other study is methylblue, the GSK inhibitor that's like lithium but without the side effects, and the other one that's the octapeptide. Those are still are pending, and so we're not going to have any information on those yet. So coenzyme Q10 right now is probably the only one that I know of. I can think of it at the time, and then DBS investigational site for the PPN nucleus.
I would just add, the way the question's worded, it does sound like the questioner was asking about new things. There are definitely older drugs, ones used to help patients with Parkinson's and other disorders that can help. They do not cure the disease, they may slow it down, but they can certainly take some steps at trying to improve the symptoms. So even though we haven't found the magic bullet in terms of a new medication, there are some medications that can be used to target specific symptoms with some benefit.
Dr. Lisk mentioned the DBS study, which is being done up in Toronto, Canada right now. This has been sponsored by, paid for by CurePSP, and they're in the process of trying this deep brain stimulation on 6 PSP patients, I believe. Another question from the same person. I've heard of doctors outside of the United States making claims of help for brain disorders. Is there any validity to these claims?
This one, it's a little tough to answer this without knowing exactly what claims the questioner is wondering about. But I'm going to venture a guess, and that it's about things of the sort like stem cells, glutathione injections, hyperbaric oxygen might fit into this category. There are quite a few things that can be found on websites with practitioners who are very willing to provide you with an injection of something. If you're just willing to hand over, $5,000, $10,000, or as high as $35,000 or $50,000. I think this is the best advice I can give is buyer beware. There are people out there who are willing to inject you with anything, and they may take their business offshore so they don't have to be under the watchful eye of government agencies. That's not to say that anything that takes place outside the United States is not okay, but I personally am very wary when I hear about United States citizens and trained physicians who are operating clinics out of the Caribbean, because to me that sounds like somebody who's trying to escape the rules. And you know, they may be able to present a case that says, hey, we're trying to get you treatment before the FDA gets around to it. But my counter to that is anyone who wants one of those treatments to become mainstay treatment for a disorder, I would really, really hope would stay within the boundaries of the United States, within the boundaries of the FDA, and basically prove to us that it works, because then everyone stands to benefit, including that particular practitioner, because then they have a financial stake in it. So the short version, if you're interested in getting involved in something of this sort, please do have a conversation with a physician, and please you know, think reasonably and rationally about potential pros and cons. Just because a website shows people happy and smiling does not mean that it's going to be a good use of your hard-earned money.
No, just means good advertisement.
Right.
I think we've covered this lithium study, so I'm going to go on to the next. I have had a movement disorder for about 3 years. To start with the fall, I first went to my primary care physician who tested me for a stroke. The results were negative. Then to a neurologist who again could not see anything wrong. Why do so many primary care physicians and general neurologists find it so difficult to diagnose these disorders?
Well, number one, when you talk, we'll start with the primary care physician. When you become a primary care physician, whether that's family practice or internal medicine, you're not doing a neurology residency. You don't have necessary neurology training. You know, many medical schools, neurology is maybe an optional month or year or fourth year. As my medical school, it was, I believe, it was mandatory your third year to do a rotation throughout neurology. And just as if myself or Dr. Szumski may not be, you know, experts in managing diabetes or COPD, and the primary care physician may have more expertise in that. The primary care physician, we can't expect them to be, you know, neurologists, because even for the general neurologist may have difficulty with this, because, you know, it would be very difficult to tease out a Parkinson's patient from atypical Parkinson. All of them look so similar, and then you throw in conversion disorders, you throw in drug-induced Parkinson's, you throw in, you know, normal pressure hydrocephalus, possible Parkinson's from encephalitis, things of that sort, vascular Parkinson's, and you can have a whole host of things. And so that's why we have specialized training after general neurology residency, where you may spend 1 or 2 years where you're only concentrating on movement disorders. And the way I explain it to people is, when you're an internal medicine physician and you want to be a cardiologist, what do? You go do a cardiology fellowship. Now you're a cardiologist. So that's kind of describe the general neurologist and the movement disorder neurologist, the difference between an internal medicine physician and a cardiologist.
I would also add that a lot of these disorders can be challenges to the highly trained movement disorder specialist too. Because the nature of the beast is that early on, the various disorders can really resemble each other. And they can resemble things that don't really even fit in the category of what we would call a movement disorder. And so very well-trained, very smart, very good doctors can be stuck with not quite enough information to be able to tell you what's going on. And so that's not, you know, an excuse, but it's an explanation for why the process sometimes takes longer than you wish it would. There are definitely some delays based on expertise, but even with expertise, sometimes the symptoms themselves don't quite declare precisely what you have, and even experts can be misled for a while.
And also, like that, sorry, did you finish or? I also like to add that, back at the, I don't know, Dr. Szumski, I don't know if you were there at the 13th Annual International Movement Disorder Conference when it was in Chicago. I remember they did, they mentioned a paper where they took a number of, I think, different movement disorders, and they had, movement disorder specialists that had fellowships and that were highly trained specialists. And they did a survey, and even, the highly trained movement disorder specialists did not get the movement disorders correct 100% of the time. So
I know there's a question later on, and I'm going to paraphrase it. What do I do if I am in the middle of Montana and it's no big city around me, no university hospital around me, no Cedars, no UCLA, no Columbia Presbyterian in New York? What do I do?
In those cases, it may be well worth your trip. If you are finding it frustrating, not having answers, identifying a center that's geographically convenient and offers the resources you're looking for, there will be cases where what is a frustrating lack of diagnosis to a primary care doctor who doesn't see it because it's so rare may be much more clear if you find a center with expertise. Now, that doesn't always mean they're going to be able to offer spectacular treatment, but at least they can give you a sense that somebody knows what it is you're up against, so that you can start using clinical trials, .gov or other sources to learn more about what you're dealing with.
My mother has PSP. We heard during Dr. Borlaug's webinar some information about Dr. Schellenberg's CurePSP-sponsored genetic program study. Can you please tell us in lay terms so that we can understand it more about this study?
Dr. Szumski, did you want to comment?
Yeah, I'll because I did review the study and reviewed some of the slides so I could give a better answer. Basically, what this study did, or is continuing to do, is take a very large population of people with PSP and CBD and look at their genes, their chromosomes, to see if they could find a linkage between a certain gene and having the disorder. And what makes the study unique is that they tested over 650,000 different spots on the human genome. It's a massive study. What they found, and Larry, do you have the slide with the actual graphic?
There you go.
That one. So what this shows, across the bottom, it shows it represents the 23 chromosomes that humans have, 1 through 22, and the X chromosome. In each bin, there are those areas represent the genes that were looked for. See if there were certain changes or findings that could be associated with the diagnosis. Anything that's at the bottom, under 3, has no relationship to having PSP. Something either everybody has or it's randomly assorted, no relationship to having the diagnosis. The higher up you go on that scale, past 3, past 5, past 7, and 7 is where it reaches true statistical significance. The higher up a dot appears, that's the more tightly linked a gene appears to be with the diagnosis. You can see the most linear one is over on 17. That represents something that's already known about the genetics of PSP. That's the tau gene, which is on chromosome 17. But there are 4 other chromosomes marked with arrows there, 1, 3, and I believe 11 and 12, that show genes that seem to be more tightly linked to having the diagnosis of PSP or CBD than would be expected by pure chance. That is exciting because basically if you count the dots above the 7, it looks like there are approximately 6. Those are 6 candidate genes that can now be studied in detail to try to unlock what they mean about developing the disorder. And it may turn out that 1 or 5 or even all 6 turn out to actually have nothing to do with PSP or no meaningful relationship that we can make use of. But in those 6 genes, it may turn out one of them is a key that we can unlock. It gives us an idea for a medication or helps us understand the triggers that start the cascade of changes that lead to the disorder. So this is exciting. It's out of a massive amount of material. It's sort of like taking the Encyclopedia Britannica and saying the answer to your question is on one of these pages. And you can ignore the other hundreds, thousands of pages. That doesn't mean the work is done, but it sure narrows it down.
Janet, are you online? Janet Edmondson?
Yes, Larry?
Can you tell a little bit about this study that was funded by CurePSP in relationship to this?
Yeah, this was the Charles D. Peebler genetics program, and this is the one that's already been mentioned that I think you mentioned that used about 300 or so autopsy brains. Many of them, about 500 or so of them, came from the Jacksonville Mayo Brain Bank that PSP works with. So we do want to put a little plug in there that if any of you are considering donating your brain, that if you go to the CurePSP website, www.curepsp.org, you can get information on the brain donation program, and we will help fund some of the costs that you might have in that. Most of the costs are already paid for by CurePSP, but the other costs that you might have locally to make this happen will help pay for it. But 500 brains came from one place, and the rest came from around the world. And I actually think that this was very well explained by Dr. Szumski, and that we are really looking now, the next step will be to verify that what we saw in this study is in fact seen again. So they're in the process of doing that study to just kind of recheck the details here. And if that turns out well, this will be put into a major scientific journal, hopefully in the spring of this upcoming year. And once it's in a major scientific journal, it gets the attention of the world researchers. And if one of these, let's say the gene on chromosome 1 is X type of gene that we already know a certain body of information about it, people who are interested in PSP and these genes can now look and say, well, what might be the mechanism that impacts that with PSP and CBD? So that's what's going on, and we'll be continuing to fund more research, and we'll be starting a major gift campaign pretty soon to start raising money to do our next phase, which would be the research that will come from announcing these 4 genes and what researchers think they want to do to actually study these particular genes in relationship to PSP and CBD. So what do these genes do that could impact PSP and CBD? And then following that research, we would then be looking at how do we stop those or change those or work with those to better have some outcomes that would affect people with PSP.
If anybody wants more information on this, there are 2 different Dr. Schellenberg slide presentations that they can request from Kate DeSantos at CurePSP. Plus, they might want to listen to Dr. Golby's presentation 2 weeks ago, where he covered this topic also. From what I understand, and I'm a lay person, it's a possible major breakthrough. My spouse has PSP. Can you tell us the latest clinical research? I think we covered that already. Okay, we're going to get copies of previous webinars by Dr. Romanowitz, Dr. Hutchman, Dr. Borlon, and Dr. Golby. And here is Kate DeSantos' information. I hope some of you have a pen and pencil to mark this down. She is the key contact at CurePSP for outreach and education. She's a director, and she has all of this information pretty close to at her fingertips. And come the beginning of the year, as Janet Edmondson has said, CurePSP is going to have a brand new website, completely updated, and every webinar that has been done will be put up on that particular website. Kate, are you there? Kate DeSantos?
Wait. Oh, okay, I'm here. I had myself muted.
Okay.
Sorry about that.
You have some questions that were submitted?
I
Okay.
do have some
I'm going
questions.
to turn this over to you, Kate. It'll take about a minute or two. Then you can start asking those questions of the doctors. Hold on one second, please.
Okay. Okay.
There you go.
Here we go. Okay, doctors, can you see my screen?
Yes, I can.
Yes.
Okay. I actually prepared a few slides based on some of the questions that were submitted. Actually, I have 3 slides, so I'll try to get through a few. I think a few have already been answered. But let's start with the first. Are many seizures common in patients suffering from PSP?
Well, this is Dr. Lisk. I have not seen seizures to be very common medical condition in PSP. I don't know if Dr. Szumski, who's experiencing.
Basically the same, yeah. And looking down farther, there's a question about seizures and strokes. I don't think there's a higher risk of having those with these disorders, but unfortunately, lightning can strike twice, and you could have PSP and another diagnosis, such as a stroke, that happens just because they happen to people. But I don't think that they're very closely linked.
Okay. Can you talk to us a little bit about what's new in MSA research?
So I looked this up on clinicaltrials.gov. It was a great example of how this works, and found that current studies in MSA are studying rasagiline, which is a medication that has been approved for use in Parkinson's disease, and there's some evidence it may even slow down the progression of Parkinson's disease. Lithium, which has its side effects, so we'll see if that pans out. An antibiotic called minocycline, which has some anti-inflammatory or antioxidant qualities, which has made it popular for screening in various neurologic disorders, and then even a study on stem cells. I suspect ears perked up when I say that. That study, I forget where it is, but it's either in China or Japan. Okay, yeah, so it's not going to be easily accessible to American patients with the disorder, but hopefully the results will be meaningful.
Good.
The next one is, I have tremor and have had DBS surgery. Are they related, and can you tell me more about this?
Well, I'd like to answer that one. The DBS surgery works very well for essential tremor. So the DBS target for essential tremor is different from the DBS target in Parkinson's disease. And the target for essential tremor is called the VIM, nucleus of the thalamus. That's the acronym. Then the target in Parkinson's disease is called the subthalamic nucleus, which we also label the STN. We already mentioned DBS surgery for PSP, but I don't know exactly what else questioner is asking about essential tremor in DBS. I'd say is it works very well for essential tremor. It works better than, I believe, DBS surgery works better for essential tremor than Parkinson's disease, even though DBS surgery is very successful in Parkinson's disease as well. Because with DBS and essential tremor, you only have one modality to treat, which is tremor. With DBS and Parkinson's disease, you have to treat subsequent things, bradykinesia, and tremor. And so, I don't know if Dr. Szumski has anything else to add.
Well, I would just add that, because I'm not sure exactly the intent of the questioner, but essential tremor is very, very distantly related to the disorders we're focusing on today. It tends to be much more restricted to just having tremor, although it may have some findings that are like Parkinson's disease, but they tend to be far overwhelmed by the nature of the tremor and lack a lot of the additional complicating symptoms that are seen in PSP and CBD.
There's one thing I guess I can add to this, is that in the Movement Disorder Journal, I think it was December 2007, there was an article published about the pathology of essential tremor. And they took brains of essential tremor patients that were given diagnosis of essential tremor, and they looked at them and they saw there were two types, pathologically there were two types of essential tremor. There were those that had degeneration of a certain type of cell in the cerebellum, and then there were those that had no cellular degeneration, just had Lewy bodies in the brainstem. They came to the conclusion that those patients that had Lewy bodies in the brainstem did not go on to develop Parkinson's disease. Now, I know Dr. Jankovic from Baylor University. He is a internationally known movement disorder specialist. He believes that there are maybe a subset of essential tremor patients that, if they have it long enough, may develop Parkinson's disease, or that essential tremor may be a precursor to Parkinson's. I think the majority opinion in the disorder community is that that is not the case. That essential tremor is separate from Parkinson's, even though you can have a Parkinson's and essential tremor rarely in the same patient, called, like a Parkinson's plus syndrome.
Okay. I think we addressed earlier, you all addressed earlier, the benefit of going to a movement disorder specialist who is a neurologist, but I don't know that we need to answer that one.
Yeah, I'll be very brief with that initially. I'll let Dr. Szumski answer that as well. The benefits, I think, of going to a movement disorder specialist is that movement disorder specialists like myself, Dr. Szumski, we go to these international meetings where you have movement disorder neurologists from all over the world. And at these meetings, we look at the most current, we're getting presented the most current research that's going on, research that is coming out. We get to know what the standard of care for a movement disorder patient is for different diseases. And, I really like to stress that when people go to someone who calls himself a movement disorder specialist, just about any general neurologist can really call themselves that, but you need to make sure that they've done a fellowship in movement disorders. The exception to that is someone who's in an academic center who only sees movement disorder patients every day. that person over a few years would definitely be just as experienced as one is in a fellowship. But that'd be my advice to patients. Make sure that the person has actually done a fellowship if they're out in the community and not at a purely academic center.
The next question is about the difference between Parkinson's disease and PSP.
That's a question that the answer could probably be an hour-long lecture or more. To get right to the heart of the matter, they resemble each other because they share certain characteristics. Stiffness or rigidity, slowness, bradykinesia. Both can eventually develop difficulty with balance. But there are some key differences that help differentiate the two. Parkinson's disease tends to be asymmetric. It tends to progress slowly when it comes to balance problems. Those are not something that typically happen early on in the course of symptoms. And most importantly, it tends to respond very strongly to medications for Parkinson's. PSP has some similar features, but it tends to be more symmetrical. The medication response is less robust, sometimes disappointing. Falls tend to be a very early issue, sometimes the overriding issue, more of a big deal than anything else. And then, of course, there are some key features that may not be at the top of people's lists when they are trying to sort out what's bothering them, but eye movement abnormalities, changes in swallowing, stiffness, and so forth. The tricky part is if we're talking about, I guess, percentages. A lot of the symptoms you see in Parkinson's can be seen in PSP and vice versa. It's the overall pattern that causes the two to diverge, and it turns out pathologically, that is looking at the tissue, that they're truly very different disorders. They just happen to affect overlapping parts of the brain.
Okay. The next question addresses sentiment, and about 30 to 45 minutes after the patient takes it, he gets very sleepy. Is this normal?
Well, with Cinemet and with all the dopaminergic medications, whether you're taking dopamine agonist, Mirapex, Requip, Cinemet, you get sleepiness with these medications. I'm not sure if she's referring to the patient's referring to the person asking questions referring to something called sudden sleep onset that could happen where someone falls asleep with some of these Parkinsonian medications, suddenly without warning, or is just excessive daytime sleepiness. When you take a dose of Cinemet, the medication, of regular release, the medication will peak in the serum in about 30 minutes after you take it. Usually patients may have something about a few years when taking medication called peak dose dyskinesias. But it's not uncommon for patients to get sleepy with medications such as Mirapex, Requip, Cinemet, and have that side effect.
Okay. I think the seizure and stroke question has been addressed already, so moving on to the next rating skills question. This may be a difficult one. With using the PSP rating scale, what score would a patient have if he or she was in an intermediate or advanced stage of the disease?
I'll be interested to see what Dr. Lisk has to say about this as well, because we may, I think your rational minds may disagree. I tend not to connect the numbers on scales with words like intermediate and advanced. In my practice, scales are very useful for research studies because you have to measure something. You can't just say, I think I'm better. You have to know what's better, how much better. You have to try to quantify it. But for research purposes, those scales are very useful. And And of course, the better the scale, the better the research can be. Clinically, though, I find it's much more valuable to focus on what the patient's actually dealing with. You may be at a stage that's relatively mild with regard to balance problems and falls, for instance, but you may have more severe difficulty swallowing than other people who have had the disorder as long as you. Is that mild, intermediate? I don't know. All I know is I want to make sure that you can swallow safely, and we take steps to make sure that we address that, and we'll address falls in, sort of level of priority. So basically in the office when I see patients, I don't really use scales very often, and I really try to stay away from things like intermediate or advanced, except at the most extremes. Because sometimes I feel like being told your disease is quote-unquote intermediate or quote-unquote advanced may give you a sense of lack of hope or lack of treatability that may not be appropriate. It may not mean that you can't be treated. It just may mean that you've accumulated more symptoms than someone else.
Yes, I have to agree with Dr. Szumski too, because when you use rating scales, you get to a question. First of all, there may or may not be a good use of your time when you're seeing a patient in clinic. And secondly, you may get to a question where the patient does not fit one of the multiple choice, answers. And like Dr. Szumski said, I find it much more useful just to, deal with the patient and what problems they're having. So I think that's how most of the movement disorder neurologists that I know are trained to do.
One just quick addendum. If you look at research studies, you will see that they may have inclusion criteria that says you have to have a certain score on the rating scale to get in, and they may label that score intermediate or advanced. Again, that's primarily for research purposes. I hesitate to use those back in the office. But you can have your answer if you look at research studies, but it'll be defined differently in different studies. People put cutoffs at different places because, again, they're trying to come up with a way to have a conversation, and labeling things in general helps the conversation, but it doesn't always help the individual.
Yeah, it also just to make sure we answer the question that for intermediate or severe PSP on the staging system, that would be the score is 1 through 5, and supposed to ignore any inability to stand up from a seated position, and so the intermediate score would be 4, severe would be 5.
The next question is, my husband is an 86-year-old with CBD. One doctor has suggested a short course of steroids that would help. What do you think of this?
Well, I don't think that steroids really have much value. What do you think, Dr. Szumski?
Well, I think if we knew for certain somebody has CBD, we don't have any reason to believe steroids would be helpful. There have been some cases recently reported of some very, very rare, very, very unusual disorders that can look like incurable progressive neurodegenerative disorders, but actually do respond to steroids. So while I certainly don't give steroids to all of my patients, there's someone I trust very much, one of the best clinical neurologists in the world, Marty Samuels in Boston. Sort of the way he put it was, as a last resort, give anyone steroids and see what happens. So you have to gauge the potential risk and the potential benefit. And if somebody's doing pretty well, I can actually harm them with steroids, and I'm very, very hesitant to do that. But if the picture is cloudy, if there are unanswered questions, if things are happening at a pace that is truly frightening and you're looking for something, there may be a time and a place where it wouldn't be a reasonable choice. But it's a it's a controversial answer. I think a question that again would generate a lot of debate at specialist meetings.
Okay. The next question is, I've had Parkinson's disease for several years, but was only diagnosed in January of 2009. How do I know? How do you know if you have PD or PSP? I guess that was something that was addressed earlier.
And here's where the value of experience in the examiner pays off a lot, to recognize the clues, recognize the pattern, and ultimately we are not, even experts are not perfect at making the diagnosis, but as time goes on under a well-trained eye, the two diagnoses really truly diverge, and you can become increasingly sure in most cases that you're on the right path. Now, sometimes the opposite does happen. Everyone is sure you have one disorder, and then some new information comes to light, and suddenly everybody is sure you have something else. That can be very frustrating, but it's one of the realities of dealing with a disorder that doesn't show up all at once.
Next question is, how do PSP and progressive bulbar palsy differ? My father's original diagnosis was PSP, but now they say he has progressive bulbar palsy.
The silence here might be, I'm not sure that I know exactly what is meant by progressive bulbar palsy. There are a couple disorders that have names similar to that, but I'm not really familiar with that. And so it's hard, for me personally, it's hard for me to say exactly what the difference is, because I'm not sure I know that I'm confident I know what progressive bulbar palsy refers to.
Maybe the questioner is asking about yeah, I'm not sure either with the progressive bulbar palsy.
But again, I mean, I think
Dr.
that.
Lisk and Simmons,
Oh, sorry.
do you think it could be Bell's palsy? I know that we had someone in our support group that had Bell's palsy, I think that's what it's called, and PSP. Just don't know.
Yeah, this is Kate. This is actually
almost certainly not.
palsy
is so different than PSP. Having them both is an unfortunate coincidence, but those two should really never be confused for one another.
The next question is about PSP and double vision. Is it common to have double vision with PSP, and are there successful ways to correct it?
Hey, excuse me, can I, before we go to that question, can I go back to the previous question before we go to the next one? I think what they mean by progressive bulbar palsy is that's one of the motor neuron diseases, not a movement disorder, and so that's one reason why it differs. It's a little bit similar to ALS. So it involves some degeneration of the cranial nerves, and so that's one way it differs, is that patients that have difficulty with chewing, talking, swallowing, reduced gag reflexes, weak facial muscles as well. But it's actually in a different neurological category than movement disorders. It's actually a neuromuscular disorder.
This is Larry Schenker again. I would just say one other thing. If this person's loved one is not seeing a movement disorder specialist at a major university hospital, I would doubt all of what is going on.
Well, given what Dr. Lisk just added, it may involve two experts. It may involve getting another expert in neuromuscular disorders to make sure that they both have a chance to weigh all the evidence. But unfortunately, this is one of the difficulties of these complex neurologic disorders. We all tend to come at them with our biases, what we're trained in, and so that's what we tend to spot first. But sometimes you have to get a couple different experts to lay eyes on something before one of them finally comes up with the most convincing case for why they have the right diagnosis.
Absolutely. And also, I think as long as you find someone that's well trained, I don't think you necessarily. Sometimes when I was in Springfield, Missouri, we had people there we had a guy there from WashU in Springfield, Missouri, from the neurology department there. We'd send people up to Washington University for second opinions, more like a feel-good consult, because whether you're at UCLA or Boston University or at the Mayo Clinic, as a movement disorder specialist, I think all of us kind of come from all of us come from universities. So, I have patients at Mayo Clinic and Washington University St. Louis, and they were just, some patients have been very happy with the consultations, and some patients have not. And I had to send a patient to Johns Hopkins, So, not necessarily, I think, where you go, but I think it's the training of the individuals where you go.
So, moving on to PSP and the double vision question. Is double vision common in PSP, and are there successful ways to correct it?
It's very common. In fact, it's closely linked to one of the key parts of the name. The progressive supranuclear palsy itself refers to some of the eye movement abnormalities that are classically seen and develop over time with the disorder, and they can often be experienced by the person with those problems as double vision. Sometimes in its mildest form, it's even just thought of as blurriness because the two eyes are pretty close in alignment and things just don't seem quite right. It can be difficult to correct. I know sometimes people have used prisms in glasses or even surgical correction of the sort that you might use on a child who has misalignment of the eyes. The problem is, because it's progressive, any one solution may only work temporarily. And it can be a real challenge. And sometimes the simplest solution is, if you're trying to read and it's double, you would close one eye. And it sounds, painfully simple, but sometimes that works better than the fancy interventions. But that doesn't mean that those can be thought about or tried. I've had people who have had some success with those interventions, but sometimes they can be short-lived or disappointing.
Okay. Can you discuss slow speech improvement? I guess they're talking about how to improve any of the speech issues that are associated with the progression of the disease.
Well, there's, as I think we mentioned before, that, some of the, like what Dr. Szumski was talking about with exercise, some of the exercise in Parkinson's we try to apply to some of the other atypical disorders. With speech, that would be the same thing. If I have patients that have difficulty with speech, I would try to, first of all, see if there's any issue with any swallowing as well. Maybe they're having weakness in pharyngeal muscles, whatnot. But if it's just speech, then trying something like Lee Silverman voice therapy with speech therapy. There's another one, Texas Voice Project, that's come out as well. That's very similar to Lee Silverman voice therapy. And trying those modalities with a speech therapist would probably be the best thing.
This is Larry again. In 2010, we're going to have a webinar specifically on and by a speech pathologist. So this would be somebody who is a expert in this particular field.
Okay. Next question has to do with additional testing in addition to sharper MRI and visit with a neuropsychologist. Do you think additional testing is needed?
I'll take a swing at this one, although I'll put a caveat in front. Asking questions like this, you're going to get a lot of wishy-washy answers from doctors who don't want to accidentally make a statement about your care because we don't know your case. That said, if there are difficulties with sleep, a sleep study is a highly valuable way of figuring out what they are and how to address them. One of the last things you want while you're dealing with symptoms of PSP is something interfering with your sleep so much that it's impacting your day-to-day function. Driving test could be quite reasonable. Concerns about driving. I'm not sure exactly what a sharper MRI means, but I assume there are differences in quality among scanners, and it might be possible to get more information out of a scan done on a scanner with a higher resolution of detail. And finally, neuropsychologists, they can do a lot of testing of cognitive function. The testing often plays out over many hours. It's very detailed. It can be somewhat tiring, but it's something that can't easily be done in a visit with your doctor in the office. It can provide information that helps you and your doctor understand what sort of difficulties you might be up against in terms of your memory, your language, your ability to process things around you in space, and other areas. So each of those, in the right hands and at the right time, they're all very valuable things to do. It's just not possible to say if in your particular case they're all warranted. But all of those are things that I would order fairly frequently on my own patients who I suspected of PSP.
Okay. The next is, my husband was recently diagnosed with PSP. Does this disease plateau in some patients, or do most patients find the disease continues to get worse and worse, I'm assuming at a more steady level?
What? Oh, stable. Yeah. With Dr. Lisk, like progressive supranuclear palsy and the first word meaning progressive, all these Parkinsonian disorders, Parkinson's, multisystem atrophy, progressive nuclear palsy, CBD, all of these are progressive disorders, so all of them will progress. With the medications we have now, we don't have a way to cure them, but we do have a way to treat them symptomatically and slow down disability.
The next is, considering that once one is in a clinical trial, you may not be able to participate in another one. If you have a recommendation of 2 trials to participate in, which ones would you most likely suggest?
I think that's a pretty loaded question, and frankly, I'm not going to say impossible to answer. There are going to be cases where you have 2 things, where a lot more is known about one. The two subjects being studied may be in completely different levels of development, and one may be relatively speaking, a shot in the dark. The other one may already have a lot of data out there. In these 2 cases, we're talking about 2 things that are both very early in the research process. And that's one of the risks of participating, is you're going to be in one and not in the other. I would remind anyone for whom this question is a struggle, Again, one of the best reasons to be involved is to look at the big picture, and you're part of a collaborative effort to not only potentially benefit from a drug that you might be put on, but to learn more so someone else will benefit later. There's a chance in any clinical trial that you'll get a placebo and won't be treated anyhow. So there may not be a right answer. The right answer may be which one is more convenient to you, which one fits with your schedule, your lifestyle, which one allows your medications to be taken, which one fits with your symptoms. And one of them may just be a more natural fit, and that, I think, would be what I would use in trying to pick which one I would participate in.
Okay. A couple more questions. My mother was treated for 2 years by a prominent neurologist in her area as having had a stroke. It wasn't until she was having difficulty speaking did we realize it was going to be something else. It occurred, I guess it was assuming that it was PSP. In the early stages of PSP, what do you consider to be the gold standard as part of the diagnosis of PSP? Could the doll eyes, quote unquote, be caused from increased cranial pressure or brain tumor?
Well, I think what they're asking with the doll's eyes, maybe they're asking about the vertical gaze palsy. That's the doll's eyes that we use for, that talks about something that we, refer to in another type of examination that I won't get into right now, but the gold standard for diagnosing PSP at this time is clinical exam and knowing the red flags diagnosis for atypical Parkinsonian disorders, looking for the gaze palsy of the eyes, not being able to look up or down, looking for early falling, looking for early dementia, and for the other disorders like MSA, looking for early autonomic dysfunction, et cetera, within the first 2 or 3 years of the onset of symptoms. And, the vertical and downward gaze palsy is not caused by increase in cranial pressure. There is the area that there's an area in the brainstem that does know with vertical downward gaze palsy that if you injured it by some other mechanism, that you could have that. And I've had some patients that are older that may have difficulty looking, may have some element of vertical or downward gaze, paresis, where they can't look all the way up or all the way down, but they don't have PSP at all, or any other type of Parkinson's disorder. I don't know if Dr. Szumski has anything to add to that.
I think, there is no single gold standard. It's a diagnosis that shapes over time. And yes, there are things that can cause eye movement abnormalities that may look very similar, but that's why taking into account the rest of the exam, the rest of the history, the imaging, and so forth is always important in trying to pinpoint what is most likely to be going on.
And another thing we had, and maybe Dr. Szumski could tell me if he agrees with this. With PET scans, it's thought that with PET scans PET scans are not the gold standard at this time. They're pretty expensive. Not a lot of places do them, and the insurance a lot of times won't even pay for them. So they're not really very accessible a lot of times to physicians to even use. But in a lot of research trials, they've been able to do PET scans with MSA, because PSP and Parkinson's, and be able to differentiate them, at a high percentile. I've seen one study that's at 90%, accuracy with PET scans with PSP. Of course, different studies are going to report different percentages. But that's the only thing I can add to that question.
Okay. Next is, I am diagnosed with Parkinson's plus, probable MSA. I have experienced a great deal of changes in the way my eyes look, which are alarmed and frightened, and my mouth is drawn in a tight, frown posture. Please explain the differences between the facial expression issues in MSA versus PSP.
Facial expressions are often used as sort of in a sense, kind of a snapshot diagnostic clue in the office. There are some patients who, when they have walked into the room, either with me or with a group of my colleagues, where our job is we've been tasked with trying to figure out what they're most likely to have. The first thing you see is it can be the facial expression, and there are some changes in facial expression that can sometimes point towards a particular diagnosis. PSP, the eyes tend to be open-wide, and the neck will often be pointed backwards. MSA can have some similar findings, some masking of facial features. Again, I apologize, but I'm sort of reading into some of these questions what I think might be the subtext, and I think I wouldn't want anyone to make too much of a story about what their own facial features were when they're trying to figure out what their diagnosis is. There are some trends, there are some characteristic things that we do recognize, but I would not hang my diagnosis on a particular pattern of facial expression changes.
Okay. And we'll wrap up this part with this final question, asking you if you are familiar with the clinical outcomes article on PSP and MSA. Do you find the dichotomy between Richardson syndrome and PSP Parkinsonism useful to you as a clinician, and do you find that info on these two very different forms of PSP useful to patients and families?
The Richardson syndrome is a subtype of that they describe in that article of PSP. And, like I said before, in clinical practice, looking at some of the subtle differences between different types of PSP is not necessarily particularly what we're doing. We're more trying to distinguish between PSP, MSA, Parkinson's disease, more on that scale. So, the research articles use things that are useful for them in the research articles. Like Dr. Szumski said, they have discussions in research meetings to more further define disorders and different subtypes, but that's not necessarily useful in clinical practice.
The reason that it might be useful someday, and the reason why research like this is important, is if there are two clinical subtypes, then perhaps there are two different kinds of pathologies that look like PSP. Then perhaps there's a way to treat one that's different from a way to treat the other. It's questions like that which drive these sorts of categorizations. In the clinic, if I diagnose you with one subtype or the other subtype, I'm still going to go back and say, what are you, struggling with the most? Let's focus on those symptoms. I can have a way of treating one differently than the other. And so clinically in the office, I don't have the ability to use those yet. But research-wise, I'm hopeful that it's a meaningful difference that may yield a way to target treatment or to improve the effectiveness of future treatment, because they may benefit one subtype better than the other. And then that distinction might be lost if we don't recognize that there are subtypes.
Kate, thank you very, very much for what you've done here. These, as I said, were questions that were submitted during this webinar by people who are attending right now. We have another 40 questions that we can ask, but I don't think we have enough time to do it. So I'm going to quickly go through some of the other questions, and maybe just either one of you, Dr. Lisk or Dr. Szumski, can answer it, and we'll just keep going on fast. My husband has been diagnosed with PSP. My husband fell and fractured his hip a few weeks ago. With his impulsivity, how can we help him to understand the safety precautions he must now take to prevent another fall?
I'll just, maybe a short answer. Huge challenge, not only in PSP, but other Parkinsonian disorders when balance is affected. And the very nature of it is that the person with the impulsivity just may not be able to logically recognize the importance of getting up slowly, moving slowly, and it does put them at ongoing risks. Some strategies can just involve having an obstacle in the way so that it's not easy to get up, but that takes away from the autonomy of the person. Unfortunately, the best way to prevent falls is to have someone keeping an eye on them to assist them when they do try to rise from a chair or walk suddenly in a given direction. But a big, big challenge.
Next question, CBD. My husband is dizzy, and I want to know what is available to help this problem.
Well, dizziness is a very broad term, and a lot of times patients, when I'm in the clinic, I try to have patients separate dizziness between feeling lightheaded as if you're going to pass out versus vertigo versus such as the rheumatism. You may treat both different types of ways. One thing a lot of physicians may use is methazine or antivert. Sometimes that does work. A lot of times it doesn't. And also, you have to see if is this an inner ear issue. You don't want to just put everything off on, PSP or Parkinson's. And so, same with the physical therapy for balance training and vestibular balance training could be very good because they have very good devices where they can help you with your balance as well.
Dr. Szumski, my wife has PSP and has a problem with bedwetting. She is in diapers and doesn't drink any liquid after 7 p.m. She takes medication but still wets. What else can I do to help her?
The details are a challenge because it's not enough information here to know precisely what the problem is. But I would encourage anyone in a situation like this to enlist the help of a urologist because there may be some studies that can help understand what is functioning well and what is not functioning well. And it may be that she's on a medication, but not the best medication. There may be other options. There are also, there are surgical options and so forth that can be tried, but those are definitely something that should be discussed with the urologist. Sometimes the best solution is, as you've done, is just try to minimize the amount of liquid that can be passed and wear some kind of garment so that there's not much comfort or trouble if there is an accident during the night.
Dr. Lisk, for you, I've been diagnosed with PSP. Can you discuss the issue of my remaining at home during the course of this disease, my preference versus having to move to an assisted living facility? The amount of money that my family will have to spend is not an issue in making this decision.
Okay, so with this question, you just have to take into account. I try to tell patients, I would want a patient to stay home as long as possible, but you also have to take into account as the disease starts to progress, the decision to go into another living facility and move away from home would have to be based on how much help you're getting at home with your activities of daily living, how independent can you be, and how, will you reach a point to where you're unable to take care of yourself or do anything for yourself, and how much support system do you have? some people have a whole family living with them, and some people may just have a couple children living in the city or within 10 miles. So all these things have to be taken into account.
Okay. Next question, Dr. Szumski. This is about feeding tubes. My husband has PSP, is in the early stages with his full mental capacities. The immediate family, me and our 3 children, have been discussing with him the pros and cons of a feeding tube. He insists that he does not want one. I and our children would like to get one. Should the family try to convince him to accept the feeding tube?
That is a tough call. The key phrase here, full mental capacities. You have someone who is able to express himself fully and weigh the pros and cons of a feeding tube. Feeding tubes sometimes seem deceptively simple and straightforward, just an easy way to get nutrition in. But they do have their drawbacks. They do have their complications. They may present different issues. My advice is to, instead of trying to convince someone to get one, try to express as clearly and as caringly as you can why you think it might be a good idea. Try to listen as carefully as you can about why they don't, and try to talk about it on those terms. And it may not be you that convince them. They may be able to convince you why they think they're making the right decision, because the decision is not the same for everyone.
Dr. Lisk, my mom has one of these disorders and has a problem accepting it. Her sister passed away in 2007 from a different disorder, and she dealt with the disease head-on. She wasn't ashamed of what she had and took advantage of everything that was presented to her. What can I do to make my mother accept her condition?
Well, let's see, we saved all the tough questions for the end. That's hard, because I have patients that I have one particular patient that comes in mind that has dementia that swears that there's nothing wrong with her, and so, and she's floridly demented. And so basically, my suggestion would be, whoever the support group is, whoever is participating in the primary, care of the patient should, have a meeting with the doctor who's treating one of these disorders. Hopefully, that's a neurologist or a mood disorder neurologist, and talk about it there. And if that does not work, then maybe referral to a psychologist to deal with coping. I would not go to a psychiatrist. I would start a psychologist, because they at this stage of the game with the situation of the way medicine is today, they're able to do their talking and deal with more issues such as coping and adjustment issues.
And I think this will be the last question, Dr. Szumski. This is from Paris, France. It's early in the morning here. Stayed up just to ask a question. My spouse is in the early stages of PSP, being diagnosed in 2008. Do PSP patients understand what is going on around them?
My short answer is yes. I think that that's something very important to keep in mind, regardless of the diagnosis affecting someone close to you, family or friend. I think your best bet at all times is to assume that they can hear you, understand you, even if they have difficulty communicating back, even if they have difficulty indicating that they're listening or understanding. It's best to assume that they can. And in PSP, my answer is essentially yes. That you should anticipate that regardless of communication difficulties and other problems, you have somebody who's going to be able to know who's around them, what's being said, and can still benefit from your comforting presence, comforting music, comforting something familiar. There's even in the worst stages of any of these disorders, just being there and just doing things that you do because to show you care are always going to be very, very highly valuable.
Well, this is the end of the Q&A session. We have a lot more questions to answer, and I know you're on the line, Janet. I'm going to suggest that we try another one of these Q&A sessions with different questions, maybe sometime in first quarter of 2010. We had over 200 questions. We tried to answer the ones we could. We tried to pick the questions that had a general interest to all of you that are attending this webinar. It's been a very long webinar. I think that Dr. Lisk and Dr. Szumski should be pretty tired, need a drink right now. We'd like to thank CurePSP, Dr. Lisk, Dr. Szumski, Janet Edmondson, Kate DeSantos, and also the Schenker say thank you.